Care Scrutiny panel today, and first of all I think we'll start with introductions. It'd be very good if the panel members could introduce themselves. I'd better go first, I should have said. Hello, I'm Councillor Jackie Ramsey and I'm chairing this meeting. Bill, would you like to go?
Yes, Councillor Bill Armour.
Hello, I'm Councillor Alison Munro, representing Almonbury Ward. Thank you.
Hello, I'm Kim Taylor and I'm one of the co-optees on Scrutiny Committee.
Hi, I'm Helen Clay and I'm also a co-optee.
Hi, my name's Jo Lawson. I'm a councillor for Crossland Moor and Neverton Ward.
Thank you. Liz, do you want to introduce yourself as an observer? Perhaps not. We'll start with yourself then. Is that all right, Simon?
Okay, hello, afternoon. So I'm Simon Riley Fuller. I'm the Associate Director of Nursing for Families and Specialist Services at Calderdale.
Good afternoon. My name is Anne-Marie Henshaw. I'm Director of Midwifery and Women's Services at Mid Yorkshire Hospitals.
Hello, I'm Dawn Parks. I'm the Director of Nursing at Mid Yorkshire Hospitals.
Good afternoon, I'm Lindsay Rudge and I'm the Chief Nurse at Calderdale and Huddersfield Foundation Trust.
Good afternoon, I'm Catherine Riley, Associate Director of Strategy at Calderdale and Huddersfield Foundation Trust.
Hello everybody, my name's Penny Woodhead. I work for West Yorkshire Integrated Care Board. I'm the Director of Nursing and Quality for Calderdale, Kirklees and Wakefield Places.
Afternoon, I'm Amanda Evans. I'm Service Director for Adult Social Care.
Yes, it's Richard Dunn. I'm the Supporting Officer for the Health and Adult Social Care Scrutiny Panel.
Before we get on to the main item that you're here for, but first of all, can we just have a look at the minutes of the previous meeting? Are we happy to approve those as correct? Yeah, thank you. Does any councillor have any declaration of interest to declare?
I'd just like, another interest is I'm employed as a bank nurse at CHFT Trust.
Okay, thank you very much. Okay. It's a public meeting. I don't think we've got any members of the public, but we will be online, so just be aware of that. We've no deputations or petitions? No. So, no questions from the public? No. All right. Okay. Thank you very much. I don't know whether we're handing to Simon or Anne-Marie, but we would look forward to your presentation. We have read the report that you've sent in the pack, so that's brilliant. And then we'll look forward to a question and answer session, if that's okay.
Yeah, thank you.
Oh, sorry.
Okay, so while the presentation's being shared, so good afternoon. I just thought it'd be worth just beginning by obviously I'm going to hand over to Anne-Marie in a short while, but it would be really good just to say, and it's at the beginning of the pack, but it's a really, really key, crucial point for all of the discussions that we'll be having, and obviously the work that we've provided to you and that will form the base of the discussion. But we are, as two organisations, committed to working in partnership to provide safe and effective care, and really importantly, a sustainable model of care for maternity services across Kirklees. We have a really strong working relationship, and again, I hope that's evidence in some of the discussions that we've had today and the information that we've provided you with. The whole programme is managed through the joint CEO-led partnership board, and that is, again, between the two organisations of Mid Yorks and Calderdale and Huddersfield. So if you just skip to the next slide, thank you. Sorry. So yeah, that's just, again, just an overview of what I've discussed. So just, we thought it'd be really helpful just to do a really brief overview of each organisation. So Calderwood and Huddersfield provides maternity services for a diverse population of women across Halifax and Huddersfield. It's a large geographical area, and it's urban and rural in nature. So again, it comes with its complexities, but it's a really diverse, rich area, which we love to serve. The service has a birth rate of about 4,500 births per annum, and we currently offer 4 birthing options. So as you can see in front of you, one of them is home birth. The other is a midwife-led care in a freestanding birth centre, which is at the HRI site, which is currently suspended. We have a midwifery-led care in a birth centre alongside the main site at Calderdale, and we have a consultant-led care on our labour ward, which we call LDRP. We also have a 31-bedded combined antenatal post ward, and with 4 designated transitional beds within that for the women, including cots, and that's also supported by a 20-cot level 2 neonatal unit facility. Mid Yorks is similar in terms of the service that's provided. So there's 4 birthing options again. Birth rate is slightly higher for this organisation with 5,000 approximate births per year. Again, same birthing options and the same issue around the midwifery-led unit, which is currently suspended on one of its sites. Again, slightly higher in terms of bed capacity, but there's a 42-bedded combined antenatal and postnatal ward. There's 5 designated transitional beds, and the neonatal facility is a 24-cotted area. Next slide, please. We've put a couple of slides together just summarising Ockenden. So colleagues, hopefully, or I'm sure will be aware of the Ockenden report, the final report being published in March of this year. We are still awaiting a further inquiry report from East Kent, and the publication for that is due on the 21st of September. But just broadly speaking, Ockenden was a large review with lots of different evidence that was gathered. As I said in the pack, they interviewed 1,486 families. Many themes, different themes identified, but essentially, regrettably, there were 3 avoidable baby deaths, 12 maternal deaths, and 498 cases of stillborn babies that were reviewed. There were 5 key themes that were identified, which you can see around. There were ranges from different themes, but governance and leadership really stood out. Staffing, and escalation and multidisciplinary working within Shrewsbury and Telford Hospital Trust. On the next couple of slides, again, a lot of this is in the briefing paper that you had, so not proposing to go through this in great detail, but again, it can be part of the discussion afterwards and happy to take questions. But there are seven immediate essential actions that were required of each and every trust, and obviously both of our trusts were involved in that. The 7 were enhanced safety, listening to women and families, staff training and working together, managing complex pregnancies, monitoring fetal well-being and informed consent. Both organisations have undertaken a huge amount of work in assuring ourselves against these 7 immediate standards, and that formed part of the Ockenden review that we had in June of this year, which I'll come to in just a sec. There were then further recommendations, again, which are listed on the current slide, which I've said, which were pulled out from some of the overall themes, the 5 main themes at the beginning. So again, I won't go through all of those, but they're on the screen there for colleagues to see. I just thought it'd be helpful. I'll just summarise and then I'll hand over to Anne-Marie. But we had our Ockenden visit where it was the regional chief midwife, the deputy chief midwife, and colleagues who came to again assure themselves against the actions that we said that we had provided against a self-assessment. It was a really supportive, engaging visit. It was very well received by the teams, and it was testimony to the teams that we've got, despite some of the challenges. That the feedback that we had was really positive, which was good. Again, I won't list all of these, but the ones that we particularly wanted to pull out were around our governance processes. So the maternity services that we felt had a really strong, robust maternity governance process in place, strengthened by some of the recommendations that were asked. But we were recognised for having a really open and responsive culture in relation to governance. We share learning really well. Just to pull out, we have a newsletter which is called the Weekly View. So this is literally a weekly view. It comes out every week from within the governance team of maternity. It ranges from shared learning, immediate actions from investigations that we've had the previous week. It introduces new members of the team, and it is a one-size-fits-all newsletter for colleagues, regardless of band, grade or discipline. And the Ockenden review team are really pleased to see that. We have a really good relationship with our Maternity Voice Partnership chair, and again, she's been heavily involved in some of the recruitment that we've had into the trust. Our Director of Midwifery, was part of that process. She's been really, really proactive in coming onto site, and again, she was there for that, so again, that was recognised. And probably just finally, we've done a lot around inequality and really trying to embed that. There is obviously work to do, and it's an ongoing process, but that was one of the things that we were really proud of, given the area that our trust serves was equality, and just generally really great MDT working. So they were some of the highlights, and I'll just hand over to Anne-Marie to talk about Mid Yorks.
Thank you. So in the same couple of weeks, Mid Yorks had their Ockenden assurance visit, and again, similarly, very, very positive feedback, particularly in relation to transparency, openness, culture, governance, and the strategies that we put in place to share learning when experience hadn't been as it should have been. So I think they were very important parts of feedback for us. I think another thing that is really important from Mid York's perspective is that the Ockenden team felt assured that our teams knew the business, and they were very open about the challenges that we have and have had through the pandemic in relation to the level of activity, the level of staffing, workforce, and the implications of those. So we were very pleased with their feedback. In the next few slides, we have provided some information about service development at both CHFT and Mid Yorks, but just to keep us to time, I'm going to move through those if that's okay. But obviously, if there's anything that you've seen that you would either like some more information about or for us to discuss, please do call that out. One of the most significant challenges that both organisations and indeed West Yorkshire and Harrogate LMS and the North of England have is around midwifery workforce. And so recruitment and retention is necessarily something that is high on our agenda on a daily basis, because the impact of not being able to achieve sustainable workforce levels, it requires constant risk assessment to ensure that we can provide safe services. And the next couple of slides describe our recruitment and retention approach and strategy in both organisations. It's broadly similar. Both organisations work as part of the local maternity system, and we have a local maternity system working group and strategy that we have implemented in both organisations. In terms of this meeting, some of the key points that we want to bring to your attention are that our recruitment and retention strategies are in line with best practice nationally. We are pursuing international recruitment. We encourage people to come back to practice if they've left organisations, and both organisations offer flexible working, which is quite a draw for people who maybe have caring responsibilities that are not traditional caring responsibilities. We have a Band 5 recruitment programme. We both participate in the local maternity system recruitment strategy and an event for newly qualified midwives, and what that aims to do is offer newly qualified midwives the opportunity to interview for a number of trusts at the same time and receive one offer. So we don't have students who in previous years might have held offers in multiple organisations, and then when it's come to the time for them to take up job, we've had gaps that we've not anticipated. So what we're trying to do is make sure that when we're at forecasting workforce, we're able to forecast as accurately as we can. Our current position, though, in both trusts, and this is a really important point, is that we are forecasting deficits into 2023-24 against Birth Rate Plus. Birth Rate Plus is the only nationally recommended model for assessing the number of midwives that you need in an organisation for the level of acuity and complexity that you have over a 6-month or 12-month period. So, in terms of the analysis that we've done to understand that forecast, we have looked at our graduate entries, we've looked at the number of student midwives that are on programme in universities in the region, and we've looked at where we predict they may look for posts when they qualify. We do deep dive into all levers, so either myself or my senior team or the head of midwifery, director of midwifery at CHFT are participating in all exit interviews, and we're analysing that data both as individual trusts and across the local maternity system. So workforce has given us a significant challenge, and part of the challenge is in relation to vacancy gaps. Part of the challenge is in relation to higher levels of sickness than we've experienced previously, and higher levels of sickness that have continued for a period of time. And in part, they're the factors that have led to the temporary suspension of both birth centres. We needed to understand more about our birth centres and the risks and the opportunities that were available around the birth centre, both now and as we look to the future. Both organisations have made a really clear statement that there isn't a corporate or a strategic intent to not reopen those birth centres when workforce improves, and I think that's a really important point. So we've worked together over the last 3 months to risk assess the structure of our birth centres, the function, the governance and the standards, and we've drawn on published European guidelines. And these have really helped us because not only have they helped us to articulate clearly our current position, they've helped us to broaden our views about what our aspirations should be and to explore opportunities for the future. Both trusts had similar findings in terms of being able to provide robust evidence about governance arrangements for birth centre and safety of birth centres. This is not a conversation about whether our birth centres are safe, it's a conversation about how we resource them and how we resource them into the future with the challenges that we've got. Both birth centres had clear leadership structures, there was excellent training provision for staff who were working in the birth centre, we analysed attendance data and birth data in some detail. I think, again, it's important to note the scale. So over the last year, there have been 149 women have birthed at Bronte Birth Centre in Dewsbury. And in 2019, at the full year period, there were 238 women who birthed at Huddersfield Birth Centre. We then looked at how many women met the criteria for the birth centre. And I'm probably stressing that because that's a really important point. Women are entitled and able to make personalised care choices that we support. So we may have some women who don't traditionally fit a birth centre criteria who choose to birth in a birth centre or at home. But broadly speaking, around about 40 to 49% of women would fit into that standard pathway criteria, which suggests that they're low risk at the point of booking. Now, there's lots that changes during pregnancy, and women do have different views. I think that the Ockenden report and the publication about maternity services and midwifery care, and particularly midwifery care outside of hospital, has definitely influenced women's decision-making. But other things that influence women's decision-making are things around the level of surveillance that they choose to have during labour, which again, Ockenden has definitely influenced views, but there's other strategies like the Saving Babies' Lives strategy, which aims to reduce stillbirth and neonatal death. So in terms of opportunity and further actions, we are in the process of establishing a joint birth centre advisory group, which includes partners from public health and our maternity voice partnership colleagues. It's a both trust group, and that group will help us to attract, to recruit and hopefully retain staff into that model of care. But it'll do more than that, because it'll help us to really focus in a way we've not focused as much before around inequality and access to services in the birth centre. We will continue our work around recruitment and retention, and we will continue the work that we're doing to continuously improve against the Ockenden actions, mindful that we're going to have another series of recommendations when Bill Kirkup publishes the East Kent inquiry at the end of September. So that was it in terms of our presentation. Over to you for your questions.
Yeah. Liz, I don't know whether you heard me, but as an observer, we'll allow you to ask some questions if you want, and I'll pick up as well when we get to, well, if they don't ask the questions I've got on my list, basically. So I don't know, I've got somebody who would like to go first. Yeah, Alison?
Thank you for your presentation. I just want to pick up on basically staffing issues initially. So you said that there's the birthing centre at Huddersfield closed because of sickness. So I just wondered if you knew what the reason was for that increase in sickness. Is it to do with mental health, or is it to do with the pressure that staff are under? And how's that, because of the closure of the two centres, the Bronte one and Huddersfield, what impact has that had on the service in Calderdale? Has that affected morale of staff, midwives there? And then I just wanted to know, you say you're involved in regional recruitment for midwives, qualified midwives, but you've not actually said whether you've been successful in attracting and recruiting midwives. So in relation to CHFT, so I wondered how that was going. And then I'd just like you to explain what the different pathways mean, or what's implicated by those pathways. So that you talk about a standard maternity care pathway, but then there's an interim or an intermediate pathway. If you could just explain what the implications of what they are and what they mean, that would be really helpful. Thank you. Sorry.
Okay, so I'll take the first 2 or 3 points there. Just tried to make some notes of what you were saying, so apologies if I missed anything. I think your first point was around sickness, and yes, it is of course it's a huge factor, and I think not just within midwifery, but generally across the nursing and midwifery workforce. And Dawn and Lindsay would agree to that there will always be sickness for different reasons, but again, the pandemic has played a massive part in that. Yes, people are burnt out and tired, and again, it's really important to stress that it's not exclusive to maternity. It's greater in the moment, and that is a big pressure, but it is a theme that we're seeing generally, and it's nationally we're seeing that. But yes, in terms of the maternity service itself, a significant proportion of that sickness has been either in relation to COVID, which has been reflected in some of the more recent figures that were provided, but also how people are feeling now as we come out of the pandemic. Morale has been a factor. We've asked people to work very differently. We asked people to work very differently at pace initially at the beginning of the pandemic. And obviously, and part of that was the organisational response to being able to provide COVID capacity on the site. It's had this discussion with Diane, who's the director, just about a week or so ago in preparation for this, and it's a weird one because people like to work where they know and they have their home units, and that has taken some time. But I think probably however we do deliver in the future, I think it will be a more blended approach. People have actually enjoyed working together. In the exit interviews that we've done within midwifery, people, and it's in the briefing paper, very, very few people are leaving the service because they are unhappy with the service that we manage. We've had quite a high turnover of retirees. I think a lot of colleagues have just got to that point where they just can't do it anymore, don't want to do it because of what's happened. I think the way that we've redesigned some of our community teams coming to work on site and vice versa, again, it's that is difficult because, again, people come into areas, people like to work in camps to some extent, and that is, again, being transparent, that is still a factor, but it's probably less of a factor than it was a year to 18 months ago, and I think it will help actually drive some of the changes that we perhaps need to make. We have mentioned international recruitment in the paper. So yes, as of hot off the press, we've committed to 5 international recruitments through NHS England. So we're just going through the process of what that will look like. And I think it's just to really want to stress the point around the workforce generally, and Anne-Marie's touched on it, is that, and again, not exclusive to midwifery, but across all of the services that we're providing, I think we're in a different world now, and we're really pushing what the art of the possible is safely, but just really challenging some of our own perceptions around what band somebody has to be or what limitations a role might have that might prevent them from doing some tasks. So whether it's international recruitment or registered adult nurse band 5 supporting within midwifery, these are the things that we're exploring that probably historically and probably driven because of the pandemic and then the associated sickness that we may not have done. So we are trying, we're very aspirational, that we know where we want to get to, but to get to that on a previous model is probably not going to happen. So we are confident that exploring these types of roles will have an impact. I think that was 3 of your points. So if there's anything I've missed, apologies.
I can probably respond to your question on behalf of both organisations around the LMS recruitment. So there are 6 maternity units in the local maternity system. 2 of the units are what I'm going to describe as smaller units. So they're around about 2,000, 2,200 births a year. They have fully recruited from the exiting graduates this year. What the graduates tell us is that they want to work in a smaller unit because they think that the workload will be more manageable for them as a newly qualified midwife. The remaining 4 units have not met their requested number of graduates to join their unit in the autumn. So I think that CHFT and Mid Yorks are in the same position as Bradford and Leeds. And I think that position is mainly because this exiting cohort were first years at the outset of the pandemic. And so their life and their lives as students changed dramatically. There was a much higher attrition than there'd previously been in healthcare related degrees and courses. The next year's exiting cohort will similarly be a smaller size but bigger than this year. And then we had a double-sized entry in 21. So the next year, 24, exit out-term point should resolve some of the difficulties that we've got now. That's the point that we're thinking we should absolutely be at in excess of full recruitment at that point. In terms of the pathways, there's 3 maternity care pathways. An intensive care pathway would be very few, usually around about 9% of women would be in that care pathway. And these are women who require additional specialist support through their pregnancy. So they'll have an obstetrician and they'll also have maybe a renal medicine consultant or a cardiology consultant. They'll have multiple other issues. Intermediate care are women who typically will have a midwife and a consultant obstetrician. So they may, for example, have had previous difficulties with hemorrhage or maybe growth of the baby. And so they're on a more intensive care pathway. Women who start on a standard care pathway are women who we would describe as being at low risk of obstetric complications. And many, but not all of these women, will receive care by a midwife as the lead professional.
Could I also, Councillor Ramsey, is it okay if I just add to that? So just in terms of some of the retention and some of the issues that Simon's described, we'd had to work differently as an organisation to support people. So we've got well-developed health and wellbeing pathways and risk assessments and offers of support right from just low-level counselling to additional support for anybody that's got any anxiety or stress as related to COVID. So we've got a whole package that we can wrap round our maternity colleagues as well as all colleagues in the organisation as well. And we've put in some additional posts around clinical education so that the newly qualified midwives at that time of transitioning, when you've qualified into your post, that they're actually really well supported to address those early months when you're just starting new in role. So we've put additional posts in there and they've been funded as well. And those are really important things to make sure we wrap around. But we also do a lot of engagement activities as organisations as well. Listening events, we like to call them, where we'll listen to what our colleagues are feeling around that and make sure that we can respond to that. And they've got time to spend talking to us as senior leaders so that we can make sure that whatever we are wrapping around helps to support them in the workplace. So I just thought I'd just add that to some of the challenges that we have about both retaining people and our recruitment and looking after colleagues while they're working within the services.
Okay, thank you for that. Just while we're on this one, I'll just pick this up. I'll come back to timeline around birthing centres. I'm sure it'll come up as something a little bit later anyway. Just, have you got an age profile of your workforce now? You've talked a lot about 2024 being the potential where we might be sorted. What's the age profile now? If most of your retirees have left, is it a young workforce?
I can answer for Mid Yorkshire Hospitals. So we do track our age profile, but we also track and have started a programme of speaking to all of our staff who are 50 plus, because what we don't know is what point are they going to retire at. We've got a workforce who are on completely different pension schemes at the moment. So some will choose to go at 55 as an exit point, some will stay to 60 or 60 plus as an exit point. So what we've had to do is go back and lay over that data that we've got about workforce with more detailed information about intent. So that's the piece of work we've got going off at the moment. At Mid Yorkshire Hospital, we've got a little bit of a, if I could draw it, we've almost got, it's like a camel's back. So we've got a group of people who are late 40s and 51, 52. And then we've got a group of people who are 25 to 35. There are two big humps. And I think from what I've seen from the local maternity system, Calderdale is broadly similar.
Yeah, it's a very similar position, and there has been work around to trying to map what that workforce will look like. And again, that has helped the predictive position that we've got. I think because retention historically has been much better. The group of colleagues who are, if we had a similar group of colleagues in a couple of years' time who are moving on, a lot of people now are leaving much earlier when they're able to retire, as in either staying or not retiring, returning. So I think, again, in trying to get to that position of where we believe it will be better, there is a group of colleagues now who will not be with us in 2 or 3 years' time. And I think that's that natural shift now that we'll see. But yeah, I think we've had a lot of, probably just for assurance as well, a lot of committed colleagues. And when we've talked about stress and burnout, these colleagues have stayed with us probably longer than they would have done, which we're very grateful for. But again, that's why these plans we put in place need to come off. So yeah, similar.
Liz, I'm very conscious you've been waiting patiently. Do you want to go now?
Yes, okay, it's fine, thank you. I just want to ask a couple of clarifying questions, please, for myself. Can you clarify, please, how long it's been since the Dewsbury Birth Centre was suspended, and how long it's been since CHFT Birth Centre has not had service? And I also would like to understand about how you've been dealing with the problems in the maternity recruitment, etc. Because for Mid Yorkshire, didn't Pontefract have a birthing centre that was closed pre-pandemic. That was closed 2019. So these problems have been ongoing for a little while, and I'm just wondering why these haven't been addressed or tried to be addressed before, and what are the timelines for your proposals? There's nothing in your presentation about timelines. Thank you.
Are you picking that up, Anne-Marie? I see you writing.
I don't want to miss any of the points. So I will speak about Bronte Birth Centre in Dewsbury. So we made the decision to temporarily suspend the birth centre in May. However, prior to May, and certainly through the end of March and April, we did have some days or some shifts when we were not able to open the birth centre because we had midwives who had, for example, rung in sick. So we weren't able to safely staff the birth centre with midwives who were familiar with the environment and used to working there. So we had a period of probably around about 6 weeks where we had what I'm going to describe as ad hoc suspensions, and it was our concern about the safety of those that led us to take the decision in May. So in terms of why haven't staffing issues been addressed, I will very sincerely say that a significant part of my role and of my colleagues' roles is around recruitment and retention. We work extremely hard to recruit and to retain staff, but the bottom line is West Yorkshire and Harrogate and the north of England have a deficit of qualified midwives. We have taken a number of different approaches, which include use of registered nurses in our workforce where appropriate to provide post-surgical care, and also nursing associates to support midwives in their activities. And we've re-looked at our support worker workforce, and that's resulted in a position where most of our support workers have done a developmental and a competency programme and been uplifted and upgraded and are working now at a higher level than they were. But the bottom line is there are parts of the role of a midwife that can only be delivered by a midwife. And we can't delegate that responsibility to anybody. So if we don't have the number of registrants nationally, we're not able to put other people into those roles.
Yeah, and similar issues, but for Calderdale, the birth centre was, for Huddersfield, the birth centre was suspended in response to the pandemic so that the space could be used to provide COVID capacity. We've then since, during and as we emerge from the pandemic, the sickness that we've discussed and also the vacancy has then prevented that from being able to safely reopen.
So for clarity, that's March 20, is it?
Sorry, yes, beginning of 2020, yeah.
Liz, is there anything you want to come back on there?
Yeah, I think it's really important that we understand all the processes that are being put in place to try and address the issues in great detail, because obviously there's a lot of things that need to be done in the West Yorkshire and Harrogate area for recruitment that's affecting both our trusts. But I think it's of a concern that we don't have either birth centre operating, and I wonder if we can hear a bit more about how the trusts are planning to work together, because I think it's really important that we understand that, because this is a change in service provision. Thank you.
Just while you're on about what the new model of service may look like and whether or not you're going to go to a birthing centre option at all across Kirklees and then to 2, could you look at timelines at the same time and then we can cover that as well?
So both trusts have made a strategic intent that we will have a midwife-led birth centre in Kirklees, and we've established
a birth centre advisory group to advise and guide on that, that's reporting into the partnership group. And I think that's really important because what that provides for us is a firm governance and leadership structure that's directed at CEO level for both organisations. In terms of the minutiae of the work, the first thing we do have to do is recruit the staff. We've just had our third unsuccessful recruitment campaign for midwives to work in a freestanding birth centre. So we've gone back to our recruitment teams to get some more advice and guidance about what other options and opportunities we might have for recruitment. So recruitment will really drive the timeline because as we found out from our risk assessment, we have robust policies and procedures, we've got robust governance arrangements, education, training and leadership. But I think that the most important thing that we do need to do is to be able to recruit into those roles. So we've had conversations and we've started to open dialogue about what should a combined recruitment campaign look like. We're at very early stages of those conversations. So I'm not able to say today we have a time frame that says in 6 months we'll be fully open with a birth centre in Kirklees that's fully staffed because at the moment we can't identify those staff.
I suppose it's hugely disappointing to feel that unless you can have a baby at home in Kirklees, you can't have a baby in Kirklees. And I think that message has been heard, hasn't it? I guess what we were expecting at some stage is to see some more robust plans about how a birthing centre could be reopened in Kirklees, even if it isn't both, if you're working together. And I think that's where we're looking for some kind of timeline around that, and whether it's a different model that you're running from one of the organisations using community staff, or whether it's a joining of workforce. It doesn't matter, but I think for Kirklees residents, it is not a good thing, and I don't think the public are fully aware that you can't have a baby at home until we've got to this public meeting. You can't have a baby in Kirklees unless you're having it at home. So, I think we feel that we want to make sure that we understand a timeline sooner rather than later on that. I'm going to just ask others for questions, and we'll keep to about 10 more minutes or so, if that's all right.
Sorry, could I just come in on something and just add in? I think it's important to note that I absolutely appreciate we want a timeline, and we do too. I think, we just need to recognise that the advisory group is just establishing, and that will, a clear action from that advisory group will be to develop the agreed timeline, and that will be based along the recruitment opportunities that we get, because as Anne-Marie and Simon have said, the staffing capacity is an absolute underlying element that will enable us to do that. I think just to add we've just agreed yesterday to increase our international recruitment for midwives. So that will be an enabling factor. There will be a delay in, when that workforce is available, but we know we are going to significantly increase that at Mid Yorkshire, so that will take us up to 25 international recruited midwives. It's new to us. We haven't done this before, so everything is on, understanding the available workforce. So as soon as we've got a timeline, we'd obviously be really happy to come back and talk that through with you, but it isn't there, but it's a real priority for us. Completely recognise that.
And as part of those options, it might not be that we reopen in the way that we did previously to start with because of the workforce trajectory. It might be that an offer is that we are open between certain hours and able to offer that service for that period. Now, again, that's not where we would want to be, but it might have to be a phased approach depending on the workforce trajectories that we've got. But it's a starting point as we go forward as an option to consider, along with the home births as well. So, as we say, we may not be able to step from this position straight to the previous position, there may be a phase-in and a different model at which we put into that timeline based on the workforce trajectories.
I'm just going to ask the other panel members, but just remind me, when did you say when the advisory group are meeting?
The first meeting is definitely before the end of September, the first meeting, yeah.
Have other people got questions? Helen?
I appreciate the, obviously staffing is an issue across all services, obviously including the maternity, and clearly there have been sort of great steps to try and fill those roles. And we obviously, you told us a lot about the how you're supporting staff and having conversations with staff about how they might change the way that they work and etc. I just wondered if has there sort of been some research or conversations with mothers who've had that opportunity denied to them, that they're having a birth that they hadn't expected in a place that they didn't expect to have it, and the impact on them and their families in not being able to have a home birth, whatever reason, but their choices being limited and not what they expected.
Thank you. I think that is a really important question. There is nationally research that's been undertaken by the Chief Midwifery Office around that very subject, because this is not a local challenge, it's a national challenge. More locally, at Mid-Yorkshire Hospitals, both of our maternity voice partnership chairs, so Wakefield and Kirklees, are speaking to women about birth choices and the impact of changes on them. And that includes women who have had opportunity during pregnancy, albeit the later stages of pregnancy, to consider their place of birth, because we're able to say to them definitively, at the moment this service is temporarily suspended, but it also includes that cohort of women who had to make changes to their plans at quite late notice. I think the key thing has been around making sure that we are as open as we can be and as honest as we can be with women, so that those women have the most opportunity to consider what this means for them. I don't know, in terms of the national research, definitely the call is still out for people who want to participate in that, so I'm not aware of a publication date yet.
It was as much about what is the, because if one place has been closed for a few months and the other one more recently, there must be at least anecdotal evidence of the impact on the women who can't give birth in a way that they want it to, or where I assume it's very difficult for them to be supported by their families when they're not in any area of Kirklees, that they can have their baby in a clinical place. But there must be something that says, you know, this is really difficult for them, or it's not at all, everybody's happy.
No, for some women it's incredibly difficult, and certainly the work that the Maternity Voice Partnership are doing definitely has more stretch and enables us to gather feedback from a broader range of women. I can't say that we've received many, if any, complaints directly from women, but I don't think that's a good measure. I think the most important measure is our Maternity Voice Partnership colleagues who are out in our communities and who have got links and associations with a number of groups who are groups of women who would have traditionally used that birth centre. But I think the issues that you raise are issues that we are uncomfortable with as well, without a shadow of a doubt. It's not something that we don't consider very seriously and take very seriously in terms of our responsibilities.
Probably, but again, from Calderdale's perspective, a really great point as well, because I think as things settle, inverted commas, of this new position. And, you know, we are less responsive to the changing, which, you know, everything was changing almost day by day. I think we do want to capture those experiences. So, as I said in the beginning of the presentation, we also have a really strong relationship with the MVP. She's really present on the site. She, again, was involved in the Ockenden review. And she, as Anne-Marie said, for Mid-Yorks, has been really key in the communication of that message. So the teams, as much as they can, will explain to the women around the options. Anecdotally, as probably similar to Anne-Marie, there are a few people, obviously, who would, you know, are unhappy about what's happened, but by and large, the feedback has been that people do understand. And again, you know, we've been very open and transparent around our position around midwifery, and I think people from a quality and safety perspective do understand when you explain to them the reasons why, from a safety perspective, why having a birth in another location is acceptable to them at that time, although maybe not ideal. But I think it's a really crucial point that we need to build in, capturing what they are saying on a more sustained basis, as you said.
Sorry, I don't wish to sort of push too far here, but I think if you're a woman having a baby and you're told that the place that you wanted to have the baby was unsafe, of course you're going to say, no, don't put me there, put me here. I think in terms of that being that's to be expected, and especially women who are vulnerable because they're pregnant, they're relying on those people to tell them the best advice. So whilst I appreciate that you're trying to give me some anecdotal evidence, I'm not sure that saying, you know, that works in terms of if you were to go to women who are not pregnant and say, if you are thinking of having a baby, do you know that you can't have one within the boundaries of the council area that you live in, then they might say, really? How unusual. But to a woman who is about to give birth and has to change because of safety reasons, of course they're going to agree with the person telling them that. Does that make sense?
Yeah, I understand. And I suppose, probably just to make the point as well, it's not that we're not providing a safe service, it's just where we're providing that service. So it's the way I've said it, but the communication, we're really clear with them. It's not an unsafe service that we would provide if it was in that location. Sorry.
All right, we've just got two more people. I've got Kim and then Liz, and then we'll just do a bit of summary up.
Thank you. My question was really around home births, because we've established at this point in time there is no other option in Kirklees for a woman to give birth other than at home. So my question is really about how likely is it for a woman that's opted for a home birth, where there's no medical problems, to be able to have a birth at home, given the nature of the workforce challenges and the sickness challenges? Or is that person likely to be told, I'm sorry, this just isn't possible at the last moment, and then perhaps transported to one of the hospitals? Because that's really important as well. I know we've spent quite a lot of time, and rightly so, talking about talking about the birth centres, but also the impact on home births as somebody's choice, given all the problems and the understanding, if I'm right, that I believe it is two midwives that maybe need to be present at a home birth, and the implication of that.
Okay. Home birth services can be fragile, and the fragility around them can be that if there is one woman or two women in labour at home, the service can manage that. If there were 3 or more women, the service wouldn't be able to provide a home birth offer to all of those women. So I think there is always a fragility, and in discussing women's choices with them, that is part of the discussion that we do have. I can only think of 2 occasions since I've been in post at Mid-Yorkshire Hospitals that in 2 years that we suspended the home birth service. And on both of those occasions, it was that we had significant late notice sickness. So it wasn't that it was something that we could have planned and changed. I can't say that we don't suspend a home birth service, but it typically is that we've already got our 2 teams out, on-call teams, out to women, and a third woman rings. Sometimes women will come in to the maternity unit and have an assessment, and then if they're not in established labour, go back home. And we've had cases where number 1 or number 2 woman has birthed and the team have gone on to number 3. But there is an inherent fragility with a home birth service, particularly when in West Yorkshire and Harrogate we have so few home births. Home birth rates are typically less than 2% in trusts across the area.
Thank you. I'm just going to let Liz, and then I know Alison sneaked in again, so you're going to end up with still 2 questions. So, Liz, please.
Yeah, thanks ever so much. Have you done, presumably you have, done impacts on the Pinderfields and Calderdale sites for following the closures of the birth units? How are they coping with the extra workloads? And have you done any assessments of whether ladies are choosing to go to other hospitals other than Pinderfields and Calderdale? So is there an impact, a wider impact on other hospitals in the area? Thank you.
We do have data, birth data, for all hospitals across West Yorkshire and Harrogate. And most hospitals have seen a reduction in birth rate. Our own reduction in birth rate at Mid-Yorkshire hospitals has been around about 300 births this year. In terms of how have we coped with the temporary suspension of Bronte Birth Centre, about 149 women birth at Bronte Birth Centre in a year. So those women have been absorbed into our bed capacity and managed. That said, because we've had staffing shortfalls across the service, again, there is a fragility of the totality of the service. But in terms of birth rate, we've had a reduction in year of about 300 births, and we have around about 149 women who birthed the previous year at Bronte, who would be coming into the Pinderfields site.
Can I just clarify that I was asking, are women choosing to go to other hospitals? Have you assessed that? So are they choosing to go to Leeds or Bradford or elsewhere? Do you know what I mean?
Yes,
rather than go to Pinderfields, yeah?
Yeah, so we every month we assess the number of people who live in our catchment area but birth elsewhere. We call them exports, and the women who we import who live elsewhere and come to us. And our numbers have remained broadly static for around about 3 years, and that's on our maternity dashboard.
Lovely, thank you. Alison then.
Thank you. My question is kind of really linked to one of my colleagues, Liz, who's just spoken. I was just going to ask, why is it that Calderdale Royal Hospital and the MHYC being able to stay open and take all the women from Dewsbury and Huddersfield when Huddersfield and Dewsbury both had to close? Because presumably you've had the sickness levels, increases in sickness levels in Halifax and at the Mid Yorkshire as well. So I just query why you've had the capacity there, and yet Huddersfield and Dewsbury have had to close.
Okay. I'm probably going to give you a bit too much of a detailed answer, so draw me out of the rabbit hole if I do. There's some real practical decisions that need to be made. So if we had, for example, a freestanding birth centre open at the moment, both birth centres would have been open with 2 midwives and a maternity support worker. Our alongside birth centres in both hospitals are very near or adjacent to the labour ward. They're run as a separate unit, but the staffing ratio per women provides one-to-one care for women in labour, but you don't need the ancillary staff that you would have if you were a freestanding birth centre. So there is a little bit that's about how are we making risk assessments on a shift by shift basis, bearing in mind the fragility of the total service because of the gaps that we've got, either through vacancy, maternity leave or absence. I think there was something else that was unique to Bronte that informed our decision making though, was that over 50% of the Bronte midwifery team are now on maternity leave themselves. So it's whilst we don't have big vacancy in Bronte, we have long-term sick and over 50% of the staff on mat leave.
Okay, I think we'll just very quickly sum up and thank you for your presentation and for answering questions so transparently, so honestly and transparently. Thank you for that. I think we've agreed with you that we would like to understand the timeline for the birthing centres and what potential model you're looking at for those, because we've obviously got that. I think we ought to express our concern that 2024 sounds too far away. So hopefully that's not what the advisory panel will come back with. We will have a discussion, and obviously we would discuss it with you if we were going to do anything that was external to this meeting in the media around what the situation is at the moment, and we would discuss that with you. But I think with that, unless Richard's got anything else to remind me about, we'll say thank you very much. For us, we just have a very short break while the next group come in, if that's all right. Okay, thank you. Thank you for, well, the quick swap over, quick change. We're going to do exactly what we did at the beginning of the meeting, so I'm sorry, Catherine, for you to sit through it again. But can we get the panel members to introduce themselves? I'm Jackie Ramsey, Councillor Jackie Ramsey, obviously chairing the Scrutiny group. Bill, do you want to start?
Councillor Kirklees.
Hello, I'm Councillor Alison Munro. I represent people in Almonbury Ward.
Hello, I'm Kim Taylor and I'm one of the co-optees on Scrutiny.
Hi, I'm Helen Clay and I'm also one of the co-optees.
Hi, I'm Jo Lawson, Councillor for Crossland Moor and Neverton Ward.
I'm just going to ask Liz if she wouldn't mind introducing herself, and then we'll come to yourselves.
Okay, I'm Councillor Liz Smage and I'm Chair of Scrutiny in Kirklees, and I'm here as an observer. Thank you.
Vicky, while you're up there, do you want to introduce yourself first?
Thank you. Vicky Dutchburn, Director of Operational Delivery for Kirklees Place.
I think we've got Chris and, Jo Halliwell and Chris. Do you want to introduce yourselves? Oh, sorry,
good afternoon. I'm Jo Halliwell and I am Deputy Chief Operating Officer and Director of Operations at Mid Yorkshire Hospitals.
Hello everybody, Chris Lennox, Director of Services for Mental Health for Swift.
Hi, I'm hoping you can hear me. I'm Darryl Thompson, I'm Chief Nurse and Director of Quality and Professions at Swift.
I think that's everybody online, so John, do you want to start?
Okay, hi everyone, my name's John Parnaby and I'm the Transformation Programme Manager for Urgent Emergency Care for Kirklees. Jill?
Hello, I'm Jan Giles, I'm Senior Primary Care Manager for Kirklees Place.
Hello, I'm Johnny Hammond, I'm the Director of Operations for Medicine at Calderdale and Huddersfield Trust.
Hi, I'm Catherine Riley, Associate Director of Strategy at Calderdale and Huddersfield Foundation Trust.
Good afternoon, Jane Claus, Chief Operating Officer, Locala.
Hi, Philip Strauss, Director of Operational Delivery at Locala.
Hi, Helen Duke, Interim Assistant Director of Operations, Locala.
Good afternoon, Andy Simpson, Yorkshire Ambulance Service.
Hi, I'm Amanda Evans, I'm Service Director for Adult Social Care.
Richard Dunn, I'm the Supporting Officer for the Health and Adult Social Care Scrutiny Panel.
Thank you, everybody. John, do you want to go forward with the presentation? We're looking...
Okay, thank you, Chair. Thank you, members. So as I say, my name's John Parnaby and I'm the Transformation Programme Manager for Kirklees. Between myself and Vicky Dutchburn, we're going to be doing like the intros and the exits of this presentation. And then we are going to be bringing in partners for what we call our insight slides. What we are hoping to do is go through the presentation at some pace in order to allow plenty of time for members to ask questions at the end. And that's why we've got a lot of partners in the room at the moment. We are doing things slightly different this year because normally we are called into Scrutiny in October to look at our winter planning. But this year we've got the opportunity to actually talk about our resilience planning at an earlier stage, and also it reflects the way that we are now working as an ICB. So it just gives us that opportunity to share some of the things that we are doing slightly differently. So what we're going to do is, like I said, between Vicky and I, we're going to be going through an outline, going through some of the insights with our partners, having an opportunity to speak to their slides, then going through some of the risks that we've identified in our system, some of the consequences, and then there'll be a lot of opportunity for questions at the end. What I won't be doing is, I know you were circulated a large information pack to go with this meeting, so it's literally only about the first 16, 17 slides that we'll be going through. The rest of the slides are all provided for your information assurance regarding what's going on in the system. So, just going on to the next slide. This is just a quote that I just picked up from NHS England, just reflecting the fact that We are about to head into winter, and it is a winter which, although this is a quote from NHS England and it is talking about healthcare services, it is going to be a very difficult winter for all partners going into winter with so many different impacts that we've got. And I'll come on to that later when we're talking about risks and consequences. So just going on to the next slide. As in previous years, all partners are involved. Sorry, Richard, are you able to move that on for me? Yeah, thank you. As in previous years, we in Kirklees have always worked as a partnership across our system, even before the talk of ICBs and ICSs came about. So these are all of the partners that we work with in order to support our system. They're all listed there. They are not numbered. We all are on the same footing. And they're all the partners that have inputs into our resilience planning, not only going into winter, but throughout the year as well. Okay, next slide. So talking about our system, we approach our system as a whole system, which is called a whole system approach. When we're talking resilience planning, that resilience planning tends to be specifically for one-off events. So we do resilience planning for heat waves, for different weather events, for problems with the state, etc. And that's what we term as our resilience planning. With a lot of that resilience planning, it tends to be led by the teams at Kirklees Council, and then we have input into that. When we come on to the winter and resilience planning, that's something that tends to be led by the new ICB, previously Kirklees CCG. And this is where we look at the different aspects going into winter as far as what is going to be happening in winter, what the expectations in winter, and what are the risks and priorities going into winter. But you'll see that between the resilience planning and the winter planning, there is an overlap there. Basically, it's all to do with managing system pressures and outbreaks. But then we also have to take into account, whilst we're doing all of this planning, the delivery of our core services. So in doing all of that planning, we still have to maintain our core services. And in doing that, we've got impacts on our urgent emergency demand and capacity, as well as demanding capacity on bed occupancy, ambulance services, etc. But whilst we're doing all of this planning and all of these considerations, it is very important to consider that we still have quality, safety, experience and inequalities is something that is common to all of that planning and is through all of that planning process. So if we go on to the next slide, this is where I'm going to do a summary very briefly as to some of the slides that you were included in the pack that was circulated to you last week. I'm not about to summarise all of those slides because my partners here, when they come onto their insight slides, may refer to some of the data and some of the indications that they've had on those. But just taking some highlights from this data summary insight. On that first bullet point, it's good to know that when we're looking at GP attended appointments, we're on an upward trend there since March 2020, which is part of a narrative that we really want to try and get out there, because I know there's people that are having difficulty having access into their primary care services, but it's not for want of having a reduced service out there. We are delivering more and more of those services. And the appointment rate within Kirklees per 1,000 population is higher than the national average. So that's something to note for Kirklees. ED attendances, which I'm sure is something that Johnny will touch on, have increased massively over the course of, not necessarily over the course of COVID, but coming out of COVID as people then started presenting at ED. But we have seen a levelling off recently, and it's not a levelling off in that it's reduced to pre-pandemic levels, it's levelling off to a more manageable level overall over the past 3 months. Then the last thing that I'd really want to just touch on there is that second to last bullet point regarding the total calls of 20 to 29-year-olds going into 111. It's interesting that this reflects the Health Watch report that we've recently had done within our EDs in CHFT recently. So it's only happened in the south part of Kirklees, in that when we were doing a big audit with Health Watch regarding people who were attending at ED, a lot of them were in that 20 to 29-year age group. And a lot of it was coming down to a lot of the people were not actually registered with GP, so they were attending ED, and I wouldn't say they were attending ED inappropriately. They were attending ED because they didn't know where else to go. So they were attending ED, and when we had this report done by Health Watch, when they were contacting a lot of these people, that were attending, a lot of it was because there were perhaps students that were not registered with a GP in the local area, or they were not familiar with the local area. So there was a lot of that reflected there, and it's a lot of the that is reflected into why this cohort of patients, service users are actually using the 111 service as well. So that is a very brief data summary insight and a very brief introduction. Vicky, I didn't know if there's anything that you wanted to add before we moved on to the partner insights.
No, I think that's a very succinct summary that you've given there, John. Thank you.
Okay, that's great. So if I can pass you over to Amanda, who's going to give the insight from a Kirklees Council perspective. Thank you.
Thanks, John. Just a brief overview, really, just to remind colleagues that the majority of people, adult social care support, are living at home in the community. And we're busy supporting those people to live with long-term conditions, the life that matters to them. Much of this work helps to mitigate the need for unplanned care through the provision of assessments and reviews, equipment and technology, carer support and arrangements to support long-term needs. One of the things that we've recently become involved with is the anticipatory care work stream. This is a collaboration across providers, so working with Locala, housing colleagues, providers of care, to coordinate care and support around people living in the community, so that agencies don't plan their interventions in isolation. And the clues in the title there are the anticipatory element of that, so that we're thinking ahead for people who might need adaptations, equipment, contingency planning there. Specific interventions when people are at a point of crisis that mitigate the need for avoidable admissions and to make sure that people are maintained at home for as long as possible include unplanned reviews. So we have a number of reviews where people's needs or circumstances have changed. We've got a hospital avoidance team that work with colleagues in the emergency departments and the same-day emergency care departments to enable people to go home on the same day and receive support in their own home. We have a mobile response and care phone service that uses technology to support people at home with significant amounts of support there that prevent demand on ambulance services and the emergency departments. And also the council provides rapid response and reablement as an element of the urgent community response service to also support people who can remain at home with some targeted interventions. With regards to discharge, we have worked to embed discharge to assess approaches, particularly through the pandemic, and we work collaboratively in both trusts now with transfer of care hubs to make sure that we get people onto the right discharge pathway. Home first is our default pathway, so we try to get people home to recover and receive rehabilitation wherever possible in their own homes. And what that means is that we do an assessment of long-term needs at a point later in their recovery journey to make sure that they better represent what they'll be able to do. So that's about having that at the right time and in the right place. And importantly, that will also factor in the needs of their carer. So we're working to strengthen our offer to informal carers, recognising that they provide a lot of support to people who've been discharged. And I think the other thing to mention is the work that we've done with our providers to strengthen the partnerships with our domiciliary care and care home providers. We have regular meetings now to talk about operational and system pressures, and that is both to raise awareness but also to collaborate with them to problem solve and to look about how we can better utilise our system resources and what we can do together so that we get the best possible outcomes for people.
Okay, thanks, Amanda. Could you move on one slide? Okay. Sorry, I didn't have my microphone on then. So if Joe would like to talk us through the Mid Yorks Insight slide, please.
Yeah, thank you, John. You'll see from, I think, the presentation this afternoon that there is a very, very, very strong theme around supporting people in their homes and in the community that will emerge through the conversations that we have this afternoon. We have got a very strong history of collaboration and system working, which we are building on for this winter. We are supplementing that with some additional hospital beds at both the Pinderfield Hospital and the Dewsbury site. And we've also invested in additional community beds, which will be available on a system basis to also help to support capacity gap that we've identified over winter. We've done a lot of work within Mid Yorkshire around ambulance handover times, both to improve patients' experience so that they're not left on vehicles for an extended period of time, but also then to ensure the availability of those ambulances to respond to further 999 calls and support that resource deployment for YAS. The other interesting thing about this winter, as well as the anticipated unplanned care demand that we've identified, some of that again linked to respiratory illness, flu and COVID, is also the continued focus and the priority on continuing the delivery of planned outpatient diagnostic and surgical cases over winter to support those patients from a planned care perspective and to continue to do the work that we've commenced around reducing those extended waiting times that were a consequence of the step back from elective care during our COVID response.
Thanks for that, Jo. So if we move on to the other side of our acute footprint, as far as now moving on to CHFT and on to Johnny.
Thanks, John. So a similar theme follows really in relation to supporting patients in their own home or people in their own home. So we have a focus on our emergency community response and community teams, really to avoid the need for referral into the emergency department. So working with our colleagues in Kirklees Council, and particularly the services overlap. And in addition to that, we are looking at direct referral from GP into our ambulatory areas, again, avoiding the need for people to go to our emergency departments. There's a keen focus on that. The home first principle, again, sort of applies, you can see in the description here, and in particular the therapy model that we have and supporting assessments in people's homes as opposed to discharge to assess beds in community beds. And the reasoning for that is that we know when people are assessed in their homes, they're less likely to need or to be seen to need the same level of social care input. So again, it's trying to use our resources most effectively and do those assessments in people's in their own homes as opposed to community beds. We're focusing on the role of the voluntary and third sector, so in particularly including the voluntary sector in our commissioning discussions that we're having. And I'll talk to the virtual ward that we are piloting, and we've included the third sector, private sector in those discussions. We've tried to make it a lot clearer for our clinical colleagues the options that are available in community. We know that because we span Kirklees, both Kirklees and Calderdale, it can become confusing at times because there are a number of services to access. So we've got a real focus on that currently in terms of making that really clear for our clinical staff in terms of discharge planning. We've also looked to increase our referrals into our urgent care hubs. So the urgent care hubs are based in our emergency departments, and we stream patients that need less input or less complex into those urgent care hubs, again, to then give space in our emergency departments so that people that have the most significant clinical complications can be managed effectively in our emergency departments. We've done a lot of surge capacity modelling, so that is one positive thing that's come out of COVID. We are very used to planning for surges in demand, and that continues into this winter. So we've got clear plans on the beds that we would use going into winter, and we've continued our point of care testing for COVID and flu, again, just to make sure that patients are not backing up in our emergency departments when we have surges in demand. And we've got a lot of focus on our board rounds, in particularly on our ward areas. So this is about effective planning and making sure that patients' stay in the hospital is as effective as possible, and we can move people back into their homes as quickly as possible. Just in terms of ambulance handover, so we've got a real focus on avoidance of long waits for ambulance handover, and we've put in place some additional capacity in order to move patients from ambulances into assessment areas within our emergency departments. and that's working with our colleagues in Yaz. And then virtual ward that I mentioned, so this is a key new development that we've been working on. I know Mid Yorks have as well, and this is commencing in October with our first virtual ward beds. And again, like I mentioned earlier, we've been linking in with the voluntary sector in terms of how they can support with that as well. Thank you.
Okay, thanks, Johnny. So if we can move on to Lacala. So colleagues at Lacala, do you want to take us through this slide?
Yeah, so I think this probably plays nicely to what's already been said in terms of it's cemented from a Kirklees point of view on the partnerships and the strength in those partnerships of the work that we've been doing. We are working on a principle of supporting from a community point of view people that don't need to go into hospital, so those patients that we can avoid an admission, and a particular focus on transferring home patients that don't need to be in hospital, and patients that we can transfer in a timely manner. We've built on a lot of the success that we've had through COVID, so the work that we did around the original discharge to assess model is built on that in terms of the integrated transfer of care hub. Johnny's mentioned the development of virtual wards, and I think the important thing to draw out is we've actually, in partnership with our community colleagues in Calderdale and Wakefield, done a lot more work to look at a resilient model. So the virtual ward model is built on a set of systems and processes that are largely standardised across both acute pathways, because I certainly recognise what Johnny says, that actually if you work in an acute hospital and you serve two footprints, it's not always that easy to find and navigate the way out for a patient, or indeed the set of services that exist in community to allow the patient to transfer home. So we have got a real big focus on trusted assessor, single assessment, but I honestly think the key difference for this year is the opportunities that we've built on through the work and the good working relationships we've got as a result of COVID.
Okay, thanks a lot for that, Jane. So if we move on to primary care, we've got Jan here who's going to take us through primary care insight.
Thank you, John. So as you've heard earlier, demand for general practice services remains very high, and practices are meeting this in a variety of ways. So as commenced during the COVID pandemic, digital approaches, whether that's online consultation or video consultation, where these appropriate, remain offered to patients alongside face-to-face and telephone appointments. Probably three areas that I would like to highlight to you from this slide. The first is that primary care networks will take on full responsibility for the provision of enhanced access. That's from the 1st of October. So all 9 of our primary care networks have submitted plans for the robust delivery of the enhanced access service. And that's going to cover the network standard hours, which are nationally set out. That's 6:30 to 8 p.m, Monday to Friday, and from 9 a.m. to 5 p.m. on a Saturday. One of the things we note is that the change means that there is no longer a requirement for the provision of general practice appointments on Sundays or bank holidays. While we know that take-up of appointments on Sundays has not been high with the previous extended access service, we do know the importance of enhanced access on bank holidays, and we've indicated to PCNs that we do intend to support wider system pressures as part of a key partner, particularly over those extended 4-day bank holiday periods. The second area I wanted to highlight with you today is about the autumn booster campaign for COVID vaccination. All primary care networks will be taking part in the delivery of this, and also a very significant flu vaccination campaign. So one of the things that nationally is anticipated is a higher flu burden. It's predicated partly on the fact that flu rates have been low during the COVID pandemic, and also looking across to New Zealand and Australia, where we see trends that happen there then come reflect what will then happen in the UK. So that flu campaign is very important. Nationally, flu will be offered to everybody 50 and over and patients in the at-risk categories. And for both COVID and flu vaccination uptake, particularly people who are significantly at risk, which include people with learning disabilities, people with severe and enduring mental health problems, these are really important categories of patient to target, and we will be doing that. And then the third area I wanted to highlight is the additional roles reimbursement scheme. So we know the problems of recruitment of general practitioners. So one of the areas that is increasing a lot is in terms of bringing a wider team of professionals into general practice. That includes people like clinical pharmacists, it includes physiotherapists. And one example of really good working between health, primary care and the local authority is with bringing in social prescribing link workers. So every practice has social prescribing link worker attached. These are really helpful in terms of assisting with managing and streaming demand. And I'll hand back to John now. Thank you.
Thanks a lot for that, Jan. So as far as our partner insights are concerned, if we can then finish with Andy from Yorkshire Ambulance Service.
So to be an effective system partner, it was very important to learn the lessons and implement the good practice that we've achieved through COVID. So that's given us much greater resilience. So some of those important lessons are around developing our clinical hub and our clinicians and the clinicians within our support services that we can move as we escalate into frontline positions to support frontline services. We've had a lot of investment within home working capability for 999 and 111, which again increases our resilience. We've spent a lot of time and effort upskilling our community first responder colleagues and patient transport colleagues into roles to work within low acuity transport. This is a fantastic enabler because it frees up 999 emergency crews to respond to Category 1 and Category 2 patients at the same time as ensuring there's patient flow around the system. We've spent the last 12 months making sure that we've got a robust recruitment process in place to make sure that our vacancies are minimal and that we're in a good position heading into the winter period. To support the system, ED avoidance is a priority. Hear and treat within our clinical hub and see and treat, making sure that there's pathways available and that they're effective and that they're embedded within our emergency crews is a priority for us. The 191 incidents that we get on a daily basis within Kirklees area, only 82 of those are managed down those accessory pathways to try and ensure that the pressure on ED is relieved. As I've already mentioned, patient flow across the system is essential for the acute trusts. So we've enhanced our PTS services that we can escalate as required. So the PTS service will come in and support the 999 service in making sure that we've got transport around the system. Workforce-wise, we've tried to diversify. We have invested a lot of time in developing our paramedics into specialist paramedics in urgent care and critical care. The urgent care paramedics we use on a rotational basis with our local GP practices. That has mutual benefits. It frees up the GP time to deal with more complex cases, but at the same time it allows our paramedics to develop those networks and increase their confidence in clinical decision making, and that is a great example of team working from that point of view. We're looking at alternative responses. We've just invested heavily in a mental health response vehicle pilot that's been used in Wakefield at the moment. And that means there's an appropriately trained paramedic with some additional training being targeted at mental health crisis patients. That's been very successful. 6% of those patients are managed through additional pathways, and that scheme has been going to be extended into Kirklees imminently. In your pack, I've put the ambulance performance response times by postcode that you requested, and also the hospital handover for Pinder Fields and CHFT. Just to echo colleagues, there's been some fantastic partnership working to support us to make sure that the ambulances are able to turn around at ED. West Yorkshire's got some of the best handover times across Yorkshire Ambulance Service thanks to their efforts.
Okay, thanks Andy, and thanks partners for those insights. Just picking up on a couple of points before we move on to the next slides regarding risk. I think what you're hearing there is obviously there's a lot of work with partners and within partners that are going on, and it's not just these partners that are in this room, it's the partners that are listed on that slide at the beginning of the presentation pack. So there is a lot going on regarding the resilience of the Kirklees system. The other thing that I would mention is, with all of that talk from the partners in the room and the presentation that you just had, it's not all about COVID, which is a good thing and a bad thing, because obviously it's still there. But previously, in last year, year before, literally every slide would have been covered in the word COVID. So it's good to see that we are moving on from that, but we're still building resilience as to anything that may happen with COVID. And the next thing I'd mention before moving on to the risk slides is, unfortunately, there's going to be a lovely new NHS term that you're going to have to get familiar with. And that's the twindemic, because we are anticipating the whole flu and COVID pandemic, if you like. So twindemic is the awful word to look out for. You know what the NHS is like regarding making these words up. So bearing that in mind, if I then just quickly take us through some of the risk slides. Previously, in previous years, what used to happen with risks and priorities and mitigations is, as part of the winter plan, there would be a section whereby each partner would have identify their own risks, their own plans and their own mitigations. We are doing it again differently, recognising that we are now working in an ICB way. So instead of having individual partner risks, we recognise there are some general risks which happen across all partners, but then there are risks that are pre-hospital, there are risks within hospital, and then there are risks coming out of hospital discharge and into the community. So that is how the next 3 or 4 slides are done. So quickly just mentioning some of the more generic risks. I'll spend more time on this slide rather than the other slides themselves. It is recognised that workforce is a huge risk across all partners, be it recruitment, retention, absence, staff burnout or whatever, and that is a huge risk within the system. And other than trying to support our workforce, we are very conscious of that within the system as well, and some of the huge vacancy gaps that we have got within some of our partners' workforces. The other risk, I've mentioned the COVID, flu and respiratory conditions, so that's where twindemic comes in. Infection prevention control restrictions, so we don't know if there's going to be more IPC restrictions brought in within the acute trusts or indeed within any of our other services, so that's a risk that we have. Money is a big thing here, so we've got the pay award there, and also the impact of the winter fuel costs of living rises as well. We've got that as a huge impact across all services as well. We've then, like I say, it's the financial pressures that we've got there with a lot of non-recurrent monies being around, including with what's known as the discharge to assess beds funding. And then we've also got the growing waiting list. So we've got a lot of risks that are across the whole system. So that's what we're just trying to highlight there. We are on with ensuring how we can meet some of those risks. So we have got about the workforce, ensuring we're looking after their well-being, the communications plans we've got across both the ICS in place have been developed and finalised as we speak. The preparation for winter monies, in one part of the system, I think that's done on the CHFT side of the system, that's done. Still working on that on the Mid-York side of the system, just 2 different approaches. The adverse weather condition and adverse weather condition plans in light of both the flooding that we had last winter and the severe heat that we had this summer. That's all been done as far as those reviews. The consistent reporting, again, has been refreshed for this year, and that's just been finalised at the moment. And then the extremist action plans as to what would we need to do in case of extreme intervention. We're considering those at the moment, going through our surging capacity and chain of command. So we're taking that through what I call our gold command processes at the moment. Going on to the next slide, as far as pre-hospital, you'll see some of these risks are also highlighted in the general risks. There you've got the home care providers, resilience against cost of living, because that is a huge concern that we do have within the market. These are not the best paid jobs, as we all understand, but with the cost of living rises as they are presenting themselves at the moment, we've got a huge concern regarding that whole industry, if you like. So it is a big concern there. Just talking about things such as the priorities, the alternatives to accident and emergency and pathways and services. We have what is known as the Directory of Services, which we are constantly reviewing. So this is utilised by our colleagues at YAS 111 so that they're able to ensure that they are able to direct patients into services that are not always at the front door of ED. So we've got a huge piece of work regarding that Directory of Services. And then the other thing that I'll mention as far as those priorities, The urgent care hub there, which is mentioned as maximised minor urgent care services. The urgent care hub is not a service as such. If you hear about the urgent care hub, this is a way that CHFT have introduced a way of working and process at their EDs in order to deal with minor injuries, who are triaged away and they're seen by someone like a GP who is based in ED, as opposed to being waiting in the ED department being seen by consultants. It's a much better use of their time if they are seen, those low acuity patients being seen through the urgent care hub process. So like I say, that's a process that we've introduced into CHFT, and it is having a lot of attention across West Yorkshire as well, as far as other providers. Urgent care in hospital, just a couple of things that I'll mention here. In hospital, infection prevention and control restrictions, reducing capacity, and just to let you know, CHFT, sorry to talk more about CHFT than my jokes, but with CHFT, they're doing a piece of work at the moment just by closing down wards and transferring patients into other wards whilst they can do what they call their deep cleans. And those deep cleans are scheduled, and it's a way of preventing infection prevention and control, specifically with DNV, diarrhoea and vomiting. It's worked successfully in previous years, so it's something that's been done again this year. And then we've got, regarding urgent care in hospital, ambulance delays and handovers. Yes, we're supporting our colleagues in YAS across the system regarding how we can support more efficient and effective handovers on that side of things. And this year, there's metrics being introduced by NHS England where the systems are going to be specifically measured on that against each acute trust site. So that is something that's going to be specifically measured against. So just going up to the out-of-hospital risks and priorities. So next slide. So again, we've mentioned here as far as the first risk, care home resilience, because this is a very fragile market. We recognise that. We've got care home support teams that are supporting that market. We've got relationship managers that support those providers. So there is a lot of work regarding that because it is a very fragile market, which is going to become even more fragile because we do recognise the cost of living increases, specifically with the likes of the fuel and energy price rises. So that's something that we're very conscious of there. And then we've also highlighted as a risk the carers' resilience, because a great partnership that we have is with carers out there, be it formal or informal carers, but these may be family members that are supporting members, their own family members out there, but it's their resilience that we have great concerns about. So we're going to be working with our third sector and voluntary sector as to how we can actually support them more, because they are a very important cog in our system. And then we've got, just for some consequences really, and this is just for consideration, because people think of things that are happening within the system, and sometimes the consequences are not particularly thought of. So just looking at a couple of the ones on there, things like ambulance diverts, where maybe an ambulance doesn't go to the nearest hospital because they are wanting to divert to a different hospital, which may be more effective for the use of that service, and it may be a quicker answer for that patient's immediate need. But you've got to think of the further consequences down the line, because if they're then admitted into that hospital that they've been diverted to, it's things like it's not good for their family and friends. That may not be convenient for them to access that hospital. Also, if that patient then needs to be stepped down into some kind of social care support or a further bed within the community, not being their own bed at home, it's how that is actually arranged, because you've then got social care teams working out of area to try and step people down into services in another area. So there's big consequences for ambulance diverts, so we try and avoid them as much as possible. We've got things that you may hear of about a single virtual contact centre. So at the moment, we have the YAS 111 contact centre. We've got the one based in Wakefield and the other one in Rotherham, is it? Yeah. So we've got those two, but there is now something which is going to be called a single virtual contact centre, whereby calls are going to be shared at times of pressure with the North East Ambulance Service. So if there's delays getting through to the YAS calls on 111, they'll be automatically diverted to NIAS, which is great as far as a response for that patient is concerned, but it's not as easy as that. If it was as easy as that, we would have gone live with that on the 1st of April, which is when we were supposed to. As it stands at the moment, it's now going to be the 1st of October. The reason being is that there are a lot of local arrangements that we have with EAS as far as things like hailing. If a patient needs to go to an ED department, an A&E, normally what happens with EAS is that they would notify that ED that a patient may be coming in. They don't have that arrangement at NIAS. So there's a disparity there regarding services. So there's things such as that, which is a consequence of going for this single virtual contact centre. And then the other thing is there's the adult social care reforms, which is going to be a huge demand going into our social care partner as far as what is going to be needed there. So if there's questions about that, when we come on to the questions and answers, no doubt Amanda will be able to answer them for you. But it's just really just to highlight when we're talking about consequences of some of the actions, that's just giving you an insight as to how they may go. And just before we go back to the chair to ask if there's any questions, can I just ask Vicky, is there anything that you want to add before we go to questions?
No, I think the only thing that I would put out there, and this is on behalf of all our partners, is that we are already working to mitigate these actions, as we are now seeing these as seasonal pressures, not just winter pressures. So we've been working since the COVID pandemic, looking specifically at our bank holidays, where we have the 4-week bank holidays, etc., to ensure that our plans are in place and are robust. Any learning is taken from those so that we're doing a continual improvement process and cycle to ensure that our plans are as robust as they possibly can be as we keep moving forward. So we're trying to get to a place where this isn't reactive, but it is planned reactions that we are doing, and we can escalate as appropriate. And I think that's all I want to add into this at this time.
Wow. Okay, thank you very much. Thank you, John, for trying to keep to 20 minutes. You didn't, but I think it was a rich amount of data that you all shared, so thank you. And also thank you very much for the packs that you've provided. We've looked at them. I'm going to ask the panel to, if they get a chance to ask questions, to try and ask them all in one go. So you know, if you can pick up. And I know Liz will ask some questions probably, and I'll pick up those that weren't asked during the process. So, right, who wants to go first? Bill, you're on.
A question and a comment mixed, and I am aware of the problems of well-meaning amateurs looking at complex situations and coming up with simplistic answers, so I'm aware of that problem. But we've got a problem with capacity, bed capacity. My wife was recently admitted to HRI through A&E, spent 3 nights there, the 4th morning, the Friday morning, told she could be discharged that day. 2:30 that afternoon, I said, well, why are we still here? Well, there's a problem in getting the medication from the pharmacy to the ward. There was no problem with prescribing it, that's been done. There was no problem with filling the prescription, that had been done. The problem was moving the packages from A to B. Now, that's not a skilled job, that's a courier's job. That could be done by anybody from, I don't know, an office junior to the chief executive. It could importantly be done by volunteers. So why have we got, and I was also at the same time, boss, after there were 4 patients on that one ward that were going to be kept in an extra night, a Friday night, because the medication was not physically on the ward. That doesn't, I'm sorry, but that doesn't seem quite sensible to me, unless I'm obviously missing something. But can we not move the floor? I mean, if that was typical, Huddersfield Rolling Infirmary that Friday night, there were at least 40 beds blocked because people couldn't get medication from the pharmacy to the ward. I'm afraid I don't see the hands, so if you'd like to comment.
Johnny, did you want to come in?
Yeah, I think it's a really important point, and we know that our processes don't always work as smoothly as they should on the ward areas. I think there are often complexities on the ward areas. We know that there's a lot of pressure on the wards. We are impacted by staff shortages and so on and so on. But having said that, I think your point is important, and I'll certainly take it away. What we're trying to do, and I alluded to it in the presentation, is we've got a real focus on what we call our board rounds on each ward, to make sure that we have a daily moment where everybody stops. They go through systematically each patient and what's the plan for that day. And in your wife's circumstance, what I would hope is that the plan around discharge, the medication being needed to be brought up from pharmacy and so on, is captured as part of that discussion and the plan, and that we have people that monitor those actions really specifically. And that's what we're trying to push. It's a multidisciplinary approach where you have that kind of stop moment on each day, but then somebody is tasked with following and making sure that those actions are completed. What I do know from other examples is sometimes communication fails because people get distracted by another task or what have you, and therefore the job isn't completed. And that's why we've got this focus on making sure that everything goes through these board rounds with a follow-up process to make sure that the actions have taken place. But what I will do with that feedback is go back and look into whether that is a broader problem in terms of just getting the medication from A to B, because I certainly know that we sometimes have delays with writing the prescription, getting what we call the TTOs done by the doctors. But that issue of actually moving it from place A to place B and that being the delay, I think that's important feedback which I'll take back.
Alison, are you going next?
Yes, I'm just interested in your risk assessment part 4, discharge and community services. And you talked about the fragile market with the care homes. So I just wondered if you were working or you had a plan B in the instance that care homes have to close due to the energy crisis, which I've seen reports about in the media. Is that something do you already have a plan in case that happens? Because the impact of that will just be so huge.
There are plans done. If Amanda, you wanted to come in with anything on that side of things?
Yeah, we work very closely with our care home market, and this year we've formed the Care Alliance. So we've got a meeting that's a structure in place now to work very closely and understand the pressures that are facing the care homes. Importantly, as part of the care reform, we've been doing a fair cost of care exercise with care homes, which we must complete by October, and that helps us to understand the cost of care in relation to the care reform, but it will also help us to understand those pressures going into winter. We have in Kirklees, our occupancy levels are about 83% now into care homes. We have seen a number of care homes close this year who've decided to exit the market. What that has done is it has the effect in supporting other care homes to have more occupancy, so that it almost has the effect of strengthening the remaining care homes where they've got, rather than have lots of care homes with large levels of occupancy, to kind of consolidate that. But as I mentioned, we have got a meeting that we have regularly with them where we can escalate issues that are being faced, and we'll work with them to make sure that we understand the impact, because there's a difference between different types of care homes as well, and we need to have that market capacity, the EMI provision, the nursing versus residential, and we're monitoring that all the time and working closely with them.
So could I just add something to that? Is that possible? Yes. Yeah, just to add to that there is recognising the financial stability of some of these organisations. Kirklees is the only council in the whole of West Yorkshire that does offer financial support as well, in that for care homes who pick up packages quickly, as in within 24, 48 hours, they get a premium of £250 one-off payment for that. And also with our dom care services, they get a one-off payment of £150 if they're able to pick up that package within a 24, 48 hours from referral. I think, is it 24 or is it 48? I think Yeah, I think it's 24. So there is that financial incentive there, which works well for the system in that we are moving people through the system and out of the hospital quicker, but it's also a financial incentive to give more monies to those providers as well.
My other question relates to the voluntary sector and the third sector, as to how robust is that? If you're relying on those sectors, how robust are they, and are they sustainable going forward?
I'll answer this and then Vicky may want to add, but I mean, it is recognised that we do use the voluntary sector, but it is a fluid and liquid workforce. You know, we do recognise that, but it is a very important part of our sector. What we do recognise is that it has really good in-reach into other areas that we may not necessarily have that in-reach into, especially in North Kirklees with some of the diverse communities that we have there. So it is recognised, but we know that we can't just fully rely on it because we recognise that it is quite a fluid organisation, if you like, fluid as far as the people that are available to it. Vicky, I didn't know if you needed to add anything.
Yeah, I think the other bit to add to that about our third sector is that we work really closely with our local authority and community partnerships around developing our community organisations to be able to support our populations, but also to recognise that and make sure that we've got that included in our directories, etc., for our other professionals to be able to utilise and access. I think the other element to that is I believe it was Jan mentioned about the social prescribers that we've got across Kirklees, both in primary care, but we've got some specialist social prescribers as well, for example, in mental health, etc. And again, they work really closely with community partnerships and our community organisations to build that resilience across that other provision that we've got available to us to make sure that we're able to support our local communities, build that self-resilience in there as well. And that all feeds back then to the way that we're able to offer grants across Kirklees with people. So we link really closely together through the strategic planning process, the priorities that we recognise that we've got as Kirklees as well to help direct some of that. But equally then, when there is opportunities, whether it's non-recurrent funding that sometimes come down specifically to support our seasonal pressures, we make sure that the third sector organisations are fully part of that process, whether it's in partnership with one of our other organisations, a statutory organisation, or for a standalone scheme that they've got. So they're continually part of this system partnership that we've got in Kirklees, and we are further developing that and growing that as we move forward. And I think the evidence and learning that we've had of some of our schemes, some we've stopped, some we carry on. We've had really good success with schemes that work direct in A&E to help divert people if they don't need to be in A&E and are being discharged from A&E during the evening. That will make sure that people get home, that people are safe, and that they've got a warm house. And we'll even at times go then do shopping if they get somebody home and realise that they've not got some basic supplies. So we've got a number of schemes that we support as a system.
I'm going to go to Liz next. She's got a hand up, and then we'll come back.
Okay, all right, thank you. So my questions are, the ambulance mental health support vehicle that's running in Wakefield, that sounds like a really good thing, and I wondered if there was any plans for expansion on that. You mentioned about help for carers and resilience for carers. Can you expand a little bit on what you're putting in to help with that risk for resilience for carers, please? You mentioned about assessment centres, so that the ambulances go into, I think it was an assessment centre. Can you confirm therefore that the handover of the patient will be at that point rather than waiting to go any further, so that we have as many vehicles as possible in circulation at any one time? And also, can I ask about access to GP appointments? Because this is still a problem for many, is actually getting an appointment for the GP. And a lot I know GPs are operating telephone discussions with people, triaging. But for some people, that's just not suitable, but there doesn't seem to be any choice. There doesn't seem to be any way around that. And I'm just wondering what discussions are happening about easier access to GPs. Thank you.
So, Jan, do you want to answer about the GPs, and then we'll come to Andy regarding the ambulance mental health support?
Yeah, thank you. So the approach to general practices is very much looking at each practice individually, because they are all different, of course. And we've highlighted earlier that there has been a big increase and continues to be a rise in patients needing appointments with general practice. So some of the things that we're doing, there is a national GP patient survey that's published every year. That came out in July, so we have information about patient feedback from that for every practice. And those practices that are struggling a little bit more for all kinds of reasons, we do targeted visits to those to talk through different ways of approaching things. So I think what I would say is there is a role for things like online consultation, for things like telephone appointments, but that needs to be very much as a partnership between the GP and the patient as to what is going to work best for them. So it's keeping that individual focus. And then, as I said earlier, it is about making the best use of the additional roles. And part of that is an education campaign. So it's understandable and not uncommon for people to say, well, I really wanted to see a GP. And that may be because we need to provide more information to people about understanding why seeing a clinical pharmacist or a physiotherapist or a different health professional within the practice might actually be a better option for them. And of course, if you don't know what it is that these different health professions do, understandably, you may think, well, I wanted to see a GP and I'm not doing. So I think it's a combination of things. It is about working with individual practices where we know they're particularly struggling. It's about encouraging practices continue to make the best offer to patients in terms of what system of access will work best for them. And it's about promoting understanding of the role of additional role practitioners and what they can offer to patients.
Just while we're on that one, can I just quickly sneak a question in? Obviously, in the pack that you sent us, 56% of patients aren't seeing a GP in primary care. They're seeing other roles. I think a lot of us watch the Panorama programme around major healthcare organisations coming into the market. Have we got a lot in our area, or have we got any?
No, we don't have. I saw the Panorama programme too. It was frightening watching. No, we don't have any of those such contracts. So all our contracts are held by individual GP practices, not by big conglomerates of practices. The exception being Locala, who hold the White House contract. It's an outstanding practice. So no, we don't have any of that sort of thing here.
Very reassuring, thank you. I'll let you get on with Liz's other question. Okay, so we've got a couple of questions,
John,
I think.
Can I just come in on that bit? Sorry, I did put my hand up. I think it's worth mentioning regarding the primary care access is that there's recently been significant amount of work around some extended access hours as well, which Jan has been actively involved in across Kirklees. So there are additional hours going into primary care to support our populations as well. So I think it's the package that's put together. It's not any one thing that's going to make a difference.
I think we've got Joe with a hand up as well. Is it on this one, Joe?
Yes, it is. Just to further reinforce that. So one of the things that we've done when we've had patients attend ED is with a primary care need is ask them the question around GP access. And quite often the initial response is, well, you can't get a GP appointment. But then when you probe and say, but did you ring your GP? Well, no, because you can't get a GP appointment. So I think there is an educational piece that we still need to do around primary care access, that it is available and it is open, because I think that message, needs to be stronger particularly across winter, and combining that with all of the other routes of help and support that might be available in the community that are neither GP nor the emergency department, because there are a lot of them, and often they are a lot more accessible and responsive in terms of timeliness. So I think there's a piece of communication around that we need to do jointly together.
Okay, thanks, Jo. Andy, do you want to come in regarding if there's any thoughts about expansion of the ambulance mental health support, and also if there's anything that you can add to dropping off at assessment centres?
No problem. So the mental health response vehicle, it's still very much been badged as a pilot scheme. So it was initially started within Hull, and it went through a quality improvement type process, RPI process, and then the scheme was extended into Wakefield. As I've said in presentation, that's going to be extended again now into Kirklees. So obviously the more patients that go through that system, the better quality of data that we get from an evaluation point of view. But at the moment, it's looking very successful. 6% of patients are managed via that resource. In terms of handover, the handover is defined when the patient is essentially off our ambulance trolley. So when the ambulance clinician hands over to the ED clinician, at that point, that's when the handover is keyed. So yes, the assessment centres won't interfere within that process, they'll only enhance it.
Okay, thanks. And then regarding the resilience of our carers out in our communities, I didn't know if there was anything that any partner wanted to add to that. Amanda?
So one of the things that we've done in Kirklees is we've put in place some contingency hours so that when paid carers are poorly or unable to care, we can rapidly put in place 72 hours worth of support, which helps us to put into position some longer term plans to support people. So that avoids that crisis of what to do with the cared for when the carer is unwell. So that provides some resilience there. We widely use assistive technology to support discharges, so the pendant alarms and the call buttons to make sure that carers who don't live in the same property have that assurance that help can be summoned as and when that's needed. We are actively trying to strengthen our offer to carers, our identification of carers on discharge, and that is about making sure that we follow them up, because I think people, when they accept that they're going to be supporting somebody on discharge in a carer's role, they often don't understand the enormity or the complexity of that support. So in our carer strategy group, we've had feedback that people can feel a little bit left behind, a week after discharge or whatever. And so we're responding to that and looking at, can we put in place a formal follow-up for carers after discharge to make sure that they're okay, and if not, to do the care navigation to get them the support and interventions that they need.
Great. Yeah, okay with that, Liz? Who's next? Jo.
Thank you. My first question is regarding the actual use of virtual wards. Is how does a patient actually get admitted to a virtual ward? Do they have to have presented at A&E, or is it through their GP? What sort of capacity numbers would you be able to support with people obviously still at home? Would it be an all year round facility? And what kind of conditions would make allow a patient to be admitted to a virtual ward? And what happens if they become ill and need to be hospitalised? Would they automatically be found a bed that they could transfer to, or are they going to have to go to the emergency department?
Okay, I'll try and remember all of those, but give me a prompt if I miss a few. If I start, and then I don't know whether Jo might want to come in as well from a Mid York's perspective. So the virtual ward scheme is something that's been rolled out nationally. It's been seen as critical in terms of moving forward with healthcare. In terms of the patients that will go onto a virtual ward, initially at CHFT, we're starting with those patients that are already in the hospital, and they'll be reviewed and they'll meet certain criteria, and we've got standard kind of operating procedures to allocate patients at the right time. They'll be supported from an outreach perspective by a geriatrician, but primarily they'll be supported by advanced care practitioners through our urgent care response team that we've already got set up in the community. So we're starting with patients that are deemed to be frail and elderly, but we also plan to roll out for appropriate respiratory patients as well. Again, building on a service that we've already got in respiratory that kind of allows us to build upon what we've already got. Essentially, it will start small, so the numbers are fairly small in October. And one of the challenges that we've had is freeing up enough geriatrician support. So we're making some adaptations in terms of how we, for the job plans for our geriatricians in order to do that. And that's one of the reasons we're starting small. But certainly we look to build this up in terms of building up our urgent community response team. And then over time, what we see is our geriatricians will do more and more outreach to support people out in the community. Once we've got going with identifying patients within the hospital, we'll then look to move to identifying patients in the community to prevent them coming in the first place. So because we do recognise you're helping people at the back end of their clinical journey, but not preempting it. So that's our focus. But again, as with all these things, we want to kind of start small and then build up, learning as we're going. But I think it's a really exciting development. We're starting with frail and elderly. We're moving on to respiratory, but there's certainly going to be options for other patients with other conditions. Did I cover everything? Okay, thanks.
Can I just check, when you say small, do you mean less than 10?
It's, yes, just about 10 for October, and then we'll look to build from there, yeah.
The numbers are prescriptive nationally around virtual wards. There is a prescriptive number per 150,000 population. So, Helen, can you just give the breakdown for Kirklees for me?
Yeah, we'll be starting off from October to have 10. We're looking at 5 frailty and 5 respiratory, and then we'll be going up to approximately 65 once we get to the end of the 18 months. So it is a new service. The referral routes in will come through like the integrated transfer of care from hospital, so be identified there. But then hopefully in January we'll be opening it up to admission avoidance, so they'll come through urgent community response. Assessments will take place. There'll be consultants who will oversee the patient care and will provide wraparound support in the community. And that's the multidisciplinary team of nurses, therapists, healthcare support workers. So, for example, you could have a healthcare support worker in on a night to support an individual to stay at home. And we'll be looking at having sort of a care and a clinical role there. Looking at using assistive technology with direct access to a consultant within ED. If the patient deteriorates, we'll be looking at direct access to the hospital for any support around further diagnostics. And if someone does become unwell, they can get direct access into that hospital. So we'll be looking at that care of transfer, but hopefully to be able to provide that acute care at home. So it is quite exciting. We've tried to use the existing pathways to make it consistent. And we're looking at a Calderdale, Wakefield and Kirklees approach. So it's the same service offer in all those 3 place areas.
Joe, I don't know whether you want to comment from Mid-York's perspective, and Vicky, I'm really sorry I missed your hand earlier, so if it's put it back up again if you want to speak.
No, nothing really to add. It's a very, very similar picture, and obviously we're looking at CKW footprint for this. The only thing that I would add is that we have appointed Susanna Sawicka, who is one of our care of the elderly lead clinicians that some of the committee might be familiar with, into a formal post via the medical director's office, which has now got clinical leadership and oversight of the whole community interface between the hospital and the community under the sort of virtual ward model. So hopefully Susanna will be integral in moving that forwards.
Great, thank you. Vicky?
Thank you, Chair. It was just going back, which is why I put my hand down about the carers issue. And I think one of the things that's worth us just mentioning is that with on both acute footprints, there is partnership work ongoing about looking at what estate is available to co-locate a number of services, specifically things around benefits, advice, support to carers, etc. So that during the certainly during winter, but during this cost of living crisis that people are going to be going through, what we'll be able to do as system partners is make sure that people are able to access more services through a one-stop shop. And I know certainly on the Mid-Yorks footprint, we've already identified, if I say some estate, Joe, on the Dewsbury site, to be able to support those partners coming in and working from a site when they're in for hospital appointments. So that's something else that we're doing to support carers, and I just wanted to make people aware of that.
Thank you. Kim, Helen, do you want to ask? No? Okay. I've just got a few. So, one of the things that I did notice in the pack that you gave us was around 2 months where there were a lot of 12-hour trolley waits at Mid-Yorks, and I'm just keen to understand what the lessons were that we've learned from those. Presumably it was nothing to do with Mid-Yorks, but it was more to do with the whole.
Joe, do you want to come in on that?
Yes, I can, Chair. Thank you. So the numbers of 12-hour trolley waits that you've seen in the report were associated with periods where the trust was actually at Opal 4, and they were clusters of trolley waits that occurred around the same time, and they were predominantly linked to very, very high attendance numbers in the EDs, and poor outflow and associated waits for bed placement within the organisation. We do a full thematic analysis of every single 12-hour trolley wait breach. We look at the patient impact in terms of patient experience, but also in terms of clinical outcomes and any potential adverse impact, because we know the research that obviously links an extended stay in ED with a poorer patient experience and outcome. I'm pleased to say through the analysis that we did, although the patient experience was poor, there wasn't any identified harm associated with those extended waits in ED. The lessons learned from that are absolutely enmeshed in the programmes of work that we're doing with the system discharge and looking at admission alternatives and attendance avoidance. So everything that we've talked about today is in line with the lessons learned out of the 12-hour trolley waits that we saw. And when we are at Opal 4, that is a system response. It's not an organisational response. So system partners and most of the representatives that are in the chamber today or online have been part and parcel of that Opal 4 resolution.
Vicky, I can see you've got a hand up, but just let me ask this one because it's related. What are bed occupancy rates normally like on a Sunday evening, for both organisations? I'm talking medical beds.
I don't mind starting, Joe, if you like. I would say Sunday evening is probably our most challenging evening of the week, generally. So we know that there are challenges in terms of discharge over the weekend. Which a lot of the focus work is about how can we streamline our discharges through the week. So it tends, I think it's a good question because it does tend to build up through the weekend, and the pressure in ED can ramp up. We do often see lower ED attendances on the weekend, which is in part mitigates that pressure that we have on beds. But generally, the pattern that we see is we increase our discharges through the week. We then have challenges discharging over the weekend, and on occasions then need to open up more beds on a Sunday afternoon, particularly in order to manage the pressure through the emergency department. So yes, I think there is a theme there, and that's something we're aware of and trying to focus on in terms of streamlining our discharges.
Yeah, our position is the same. So irrespective of time of year, irrespective of system or organisational pressures, our discharge pattern follows almost the same sequence every week. So Thursday historically is our highest discharge day of the week, and it has always been that way. And our discharges then tail off over the weekend. We are doing a lot of work around trying to even out that variability on a day-by-day basis. So there's variability within the week, not just between the week and the weekend. The weekend is difficult because there are certain pathways that aren't available to us on the weekends, and there are certain restrictions around discharge numbers that apply during the weekend that don't apply during the week. But that's the system piece that we are undertaking across Kirklees and Wakefield with all of our partners around how we can improve on that. Some of this is linked back to Johnny's point earlier on, which is about proactive discharge planning. So moving our discharge planning so that you almost start to discharge plan on admission, not at the point at which people are ready to leave the organisation and move on to their next point of care delivery. So that's the work that we're concentrating on with our clinical teams at the moment.
Thank you. Vicky.
Thanks. There's 2 points that I think I'd like to make. So if I make the first one, which is on the discharge planning and the 7-day working, and I think, as Jo says and Johnny, that this is a system piece of work that we are working on and we have been doing for quite a long time. And all our partners are flexing their workforce now. So social care are flexing their existing workforce to ensure that there's staff available on weekends to promote and support discharges. But it's one of those areas that we're working to try and ensure that we've got all the ducks aligned, is the only way that I can describe it, because if one part of the system is ready to go first and starts, so for example, if the trust start having consultants on a Saturday and a Sunday and they're writing lots of discharge notes and doing TTOs, but we haven't aligned the social care and the care homes, etc., to be able to work at that same pace, then we end up with a mismatch. So we're trying to align those. So I think that's an important one, and it is a priority for the system. The other one that I put my hand up originally to mention was regarding the 12-hour trolley breaches, and Jo, I think you did yourself a little bit of a disservice there as well in your explanation. So one of the things that Mid-Yorks took a decision to do when the new ambulance handover targets and requirements came through was that they weren't going to fail the handover targets. So regardless, they were accepting patients off the ambulances so they could turn the ambulances around at a fast rate to ensure that the crews were staying out on the road, which was really positive. But that in itself then caused those additional problems because the patients were then in the hospital, and it was about that flow through the hospital. The additional element that caused some additional pressures, specifically at Mid-Yorks, was some of the neighbouring hospitals that were struggling, and I'm going to name Leeds in this because we saw it from Leeds and North Yorkshire, where they were struggling with ambulance handover times. Patients were coming into Mid-York, so it increased the numbers that were actually coming in through those ED departments, and we saw a direct correlation, and we're mapping that as part of the learning. So part of it, I think, was Mid-Yorks became a victim of their own success. So they were succeeding at some targets, but it had that consequence that we then had to map through. So I just wanted to put that out there because it was something as a system we were fully sighted on and supporting the trust to deal with.
Yeah, it's a really difficult one, isn't it? Whether you take the risk of people being at home and not getting an ambulance, or you take the risk of an ED department that's overwhelmed and staff can't get to all the patients. So thank you for that. I think my last question, you'll be absolutely delighted to know, is one about mental health patients in ED departments and how smoothly that's running around getting them assessed and getting them to the appropriate place.
Yeah, I don't know whether...
Danny, do you want me
You're on mute,
that is
Chris.
from Mid-Yorkshire?
Yeah, I can come in, sorry. The performance around our ability to support people in ED departments is really strong, and we consistently overachieve on that performance. Our mental health liaison teams respond very quickly within 1 hour, and we have home-based treatment teams that work in partnership with ED departments for those people who need more input or further pathways on. So whilst it's always a challenge, and whilst we have been involved in some of the breach situations, they're often for very complex people, and the solution is not easy to find either for ourselves or other partners. But we do work very collaboratively. We have performed consistently well, and we're pursuing lots of initiatives to keep people away from ED departments in the first place, which generally the investment in the system in Kirklees has been very beneficial to us in developing those solutions, and we'll continue to do that. So I don't think we have a particular challenge. We are continuing to work, and there's obviously no scope for complacency, but we do work very collaboratively with partners, looking at how we can meet the needs of those people throughout the 24-hour period.
Did you want to come in, Johnny, or Joe?
Only just to say, I think the working relationships between the teams are really good. There's no doubt that there are, on occasion, some very challenging patients. And I can think of examples where we've had challenging patients that have been in the department, deemed medically fit, have then absconded. We need to bring them back. We need to go through the process again. It can be very challenging, but the working relationships are very good, and we always find the mental health liaison team responsive. I was just going to mention that we do have work streams focusing on those patients that return to ED repeatedly, so sort of like our frequent flyers, to really understand why it is that they keep turning up, and that's a joint system-wide piece of work as well, which has been beneficial.
Yeah, I would just add to that in that we are very carefully mapping the increased presentations for people with a mental health condition, either as the sole reason that they are presenting through unplanned care, or as an additional element of their presentation and care. As Chris has said, the assessment and the assessment process, I think, is really robust and very timely. I think the challenge that we've got is where that requires a mental health inpatient bed placement is where we really sometimes struggle in terms of the accessibility of that in a timely way. And also in terms of within the hospital, patients who have got a medical requirement and therefore do need to be in an acute secondary care hospital but present with very difficult behaviours is also an increasing feature. So we are seeing more and more people that are requiring a higher level of support, be that 1-to-1 or even 2-to-1 or 3-to-1 sometimes, which is against the backdrop of some of the staffing challenges that we've articulated, can be also quite challenging as well. But as a system, I think we are all well rehearsed in some of those challenges and are working collaboratively together to try and resolve that for patients as quickly as possible.
Thank you. So, sorry. Oh, sorry, Darryl.
Just to support what Chris is saying, I guess it's been interesting listening to conversations over the course of the day when we've been talking about virtual wards and thinking about all of the work that happens before people get to A&E and the work of our intensive home-based treatment teams. And part of our reflection is what might be the commonalities between how we define a virtual ward and the caseload of our intensive home-based treatment team. I guess also to flag, whilst we've got these challenges now, picking up on Vicky's earlier point about the cost of living crisis and the predictable impact of that on our population's mental health, and in particular on suicide risk, is something that we're acutely mindful of.
That was just a really bad point to finish, wasn't it? So sorry about that. I'll try and turn it around. Thank you so much. Thank you for your honesty, transparency, for the information that you provided. There are a lot of problems in the system. We recognise that. We're obviously very concerned, as you will be, around what actually is happening with the workforce and what will happen over the winter period. Yeah, but thank you very much for your presentations. I don't think there is anything else that I need to say, unless anybody else has got anything specific. No? All right. Thank you. Next bit on our agenda is the work plan. So I don't know, I mean, obviously it's good that we've got some things that are coming up on the work plan that have been referenced today. So in December, we've got the adult social care reforms, and in October, I don't think we're covering workforce, are we, as such. In fact, it's mainly around finances, around the resources, but I think workforce is going to be a real big theme. Do you want to just have a quick look and make sure, is there anything that you're concerned about with the work plan? Is there anything that you want us to bring back from today? We will schedule maternity back in, and do we normally do a bit of a catch-up with unscheduled care January, February, or what do we normally do? Do we not? So should we just touch base with them as organisations and then decide whether or not? I mean, they'll be busy then. We don't want to be bringing them into a meeting when there should be an A&E. So, Helen.
I was just thinking that the questions that we might have considered that we were about to ask earlier would actually be covered in here around capacity and the services, and it would be actually a bit more live then as well, so that we could drill down a bit more in terms of community services and how they're coping.
Okay, so we'll consider the work plan still valid and agreed, and the schedule okay. And then I think that's it. I think we can draw the meeting to a close unless there's anything anybody wants to raise. No? Richard? Thank you again for your patience. It's 2.5 hours, but you did very well.